Got very quiet in here. All right. So welcome everyone. Thank you for joining us in person. We also have quite a few folks on Zoom. So this is being live streamed. So we appreciate all of you being here, both in person and virtually. And my name is Katie Schubert. I'm president and CEO of the Society for Women's Health Research. And we are really thrilled that you all are taking the time to join us today. This is Women's Health Month. So happy Women's Health Month for anyone who celebrates, which should be all of us. And today's briefing is exploring obesity's impact on women and policy's role in improving outcomes. And here, together with our panelists, who I will introduce shortly, we're going to explore how women living with obesity might be disproportionately impacted in terms of risk factors, health outcomes, and costs of the disease. And for those of you who are not familiar with SWHR, we were founded in 1990, and our mission is to advance women's health through science. Thank you. Lindsay's like, so advance the slides. Too many things in my brain. Our mission is right here. So that makes it easy for me, right? To advance women's health through science, policy, and education while promoting research on sex differences to optimize women's health. At the end of the day, our vision is to make women's health mainstream. And all that means is that we're not even needing to consider whether there are differences between men and women or amongst women. It's just built into the research and healthcare spectrum. So we're all here to do that. So SWHR began its obesity program to delve into the impacts of the disease of obesity on women in particular, including examining which risk factors were unique to or more common in women, what barriers may exist to women in terms of their access to treatment or preventive services, and then how federal policies might be supporting or hindering that process. And as with most of our programs, we tend to convene, right? We have a very broad organization in terms of women's health. So we convene a series of interdisciplinary roundtables where we have important conversations surrounding women's health. And in this particular case, we convened our group in February of this year, which was not that long ago, although we've lived years, decades since then. But we convene researchers, clinicians, patient advocates, and policy experts to talk about these gaps and opportunities that we're seeing in terms of women living with obesity. And that roundtable itself and that conversation serves as the foundation for all of the program that we're engaged in and informing all of our future work, including today's briefing and an upcoming patient experiences webinar. And that's all going to culminate in the release of a policy agenda, which we hope will provide a roadmap for lawmakers to support women living with obesity in the United States. We are tremendously grateful for the partners and subject matter experts, many of whom are here with us today, who continue to take the time out of their busy schedules to participate in our work, help us fully understand the issues that people are facing every day, and share their expertise and insights with us. So we are of the firm belief that those types of partnerships and collaborations are really important to all of the work that we do and the key to success. I'd also like to thank Novo Nordisk for their support of this program and note that SWHR maintains editorial control over all of our work products and programming. And we had hoped to hear from Congresswoman Shrifalis McCormick. Unfortunately, she had an unforeseen circumstance come up. So we unfortunately will not be hearing from her, but thank her so much for her support in this area. She introduced the World Obesity Day resolution. She's been a strong supporter of all of these policy issues and a good partner in this process as well. So let me I'm going to introduce all of our panelists, and then we're going to move through the program, and we hope to have time. I think we will have time for some questions and answers at the end. I am monitoring the Zoom chat and Q&A. So for folks online, just pop them in the chat or the Q&A, and we'll make sure we'll try our best to get to all of them. So first up, we will have Dr. Lisa Bailey-Davis, an Associate Professor of Population Health Sciences and the Associate Director of the Center for Obesity and Metabolic Research at Geisinger, a large integrated health system in rural Pennsylvania. And she's also faculty in the Department of Nutritional Sciences at Penn State and a registered dietitian. Dr. Bailey-Davis's research addresses both structural and social determinants of health with the goal of improving nutrition, food security, and health equity for rural, low-income maternal and child populations. Following Dr. Bailey Davis, we will have Patty Neese joining us, who is a dedicated member of the Obesity Action Coalition, currently serving as chair of the OAC Weight Bias Committee and is the immediate past chair of the OAC National Board of Directors. She's an advocate for sound obesity treatments and the eradication of weight-based bias, stigma, and discrimination, and encourages change by sharing her own experiences of living with obesity. She's a member of the National Academy's Roundtable on Obesity Solutions, the World Obesity Federation's Policy and Prevention Committee, and the International Obesity Collaboration. And following Patty, we'll hear from Dr. Tiffany Powell-Wiley, who is an Earl Stadman tenure track investigator with a joint appointment in the cardiovascular branch of the Division of Intramural Research at the National Heart, Lung, and Blood Institute and the Intramural Research Program of the National Institute on Minority Health and Health Disparities. She served as an assistant clinical investigator at NHLBI, held a joint appointment in the NCI's Office of the Associate Director of the Applied Research Program, and served 2 years as a clinical research fellow in the Reynolds Cardiovascular Research Center at UT Southwestern Medical Center in Dallas. And then finally, Dr. Tracy Zvenich, Director of Policy Strategy and Alliances at the Obesity Action Coalition, where she provides leadership in the development and implementation of policy priorities and strategies for the OAC and represents OAC and alliances and coalition efforts to advance obesity care. She's also serves as adjunct assistant professor at Georgetown University, where she teaches healthcare policy and advocacy to graduate level students. So lots of wonderful speakers with really important credentials. I am very impressed. I have imposter syndrome here, sitting here. But with that, I will go ahead and turn it over to Dr. Bailey Davis.
Thank you so much. Hello and good morning. I'm Dr. Elisa Bailey Davis, and it's my pleasure to be here with you today to share life course perspectives related to women's health and obesity. And in the spirit of serving the women at Geisinger, there are three generations of women at Geisinger pictured on a slide. So what do I mean by life course? If we're lucky enough, it's the 100 years that we get to spend on the earth and the different stages from infancy through childhood to adolescence, early adulthood, and older adulthood. And the life course approach really assumes or recognizes that the health and experiences that we have in one stage influences future health. But it also takes a broader perspective, something related to the 100-year effect. And that means, like, from science, we know that findings from longitudinal studies provide evidence about the sex differences between men and women related to obesity and when they present at various life stages. So, for example, children whose mothers were in utero during periods of famine were heavier at birth, so at the infancy life stage, whereas children whose fathers were in utero during periods of famine were heavier during adulthood, so a different life stage. And next slide. So as evidence is emerging, it's an exciting period of time. So there's the Women's Health Innovation Opportunity Map that really helps to identify and understand topics, priority topics, as well as leading opportunities and solution strategies to identify what are really large gaps in what we know regarding the sex and gender differences related to non-communicable disease and chronic disease like cardiometabolic conditions, including ischemic heart disease, diabetes, and obesity. So the leading opportunity here that's called out in the 2023 map is to understand and evaluate sex and gender related differences in the evolution of and presentation of cardiometabolic conditions, including obesity. So that's a signal that we don't know very much about the sex and gender differences at this point. I'm going to talk a little bit over time in the presentation about what we know in differences of prevalence and risk factors across the early life stages. But there's not a lot to share regarding the mechanisms and how they present, and really having a better understanding of how to prevent and how to treat women's health related to obesity. So to be sure, obesity is recognized and widely acknowledged as a chronic, progressive, relapsing, and treatable disease. and it is a contributing factor to cardiometabolic diseases. And on the left of the slide are some talking points from the American Heart Association's Go Red for Women. And I'm just going to point out the point number 1 and point number 3, that cardiovascular disease kills more women than than all cancers combined. And in the third point is that cardiovascular disease is also the leading cause of death in new moms. So if you look to the right, that's the solution strategies from the opportunity map that was published last year. And that's quite a robust research agenda that identifies all the gaps that we have in knowledge related to sex and gender differences, related to cardiometabolic and conditions, including ischemic heart disease, diabetes, and obesity. So we need to continue to pursue research so that we are able to answer these questions and provide better, more effective population level prevention, as well as personalized medicine. So what do we know about the prevalence of obesity among children in the United States? So going back to that life stage. So these data are nationally representative samples of data from the National Health and Nutrition Examination Survey, or NHANES, from the period of 1999 through 2016. And these two graphs compare girls and boys in the different prevalence. And on these graphs, they also call out different classes of obesity. And I'll just translate that for children to adulthood. So class 1 obesity in children is similar to a BMI of 30 in adulthood. Class 2 obesity in children is similar to an adult BMI of 35. And class 3 obesity in children is similar to an adult BMI of 40. So it gives you a little bit of perspective. And when looking at these groups of children, 2 to 19 years of age, girls versus boys, there are not significant differences in the prevalence. But when looking deeper at these data that were published, I think in 2018, we do find that among the 2 to 5-year-old group and among the 16 to 19-year-old girls, there were significant increases in class 1 and class 2 obesity. And those are causes for concern. And another national sample of children in the United States that participated in the WIC program identified that severe obesity, or class 2 obesity, has been increasing really more in girls than in boys. So that's among our youngest children, who are ages 2 to 4 years of age, and already showing disparities between the girls and the boys. And then also, once it's established early in life, obesity is progressive and it persists. So this overall graph is from Dr. Ward's study, and he looked at data, or they looked at data from 2016 in NHANES, and regardless of the child's weight status at age 2, they predicted the likelihood that they would develop class 1 obesity by age 35. And actually by age 35, they predict that 60% of children who were age 2 in 2016, regardless of their weight, will have class 1 obesity by age 35. And then when looking at their supplemental data from this study, they looked at if children had class 1 obesity at age 2, what was the likelihood of, what was the progression to age 35? And what they found is particularly true among the girls with a higher burden, again, that they were more likely to develop move from class 1 to class 2 obesity by age 10. That would be 1 in 4 girls. By age 25, it'd be 1 in 3 girls. And by age 35, 57% of the girls who started with class 1 obesity would have class 2 obesity by age 35. And I want to just point out that for children, establishing obesity early in life carries with it the greatest metabolic risk, and they will present with adult onset of cardiometabolic conditions by age 11 and 12. So what can we do? So this graph comes from the early origins of obesity. I think it was presented at the Institute of Medicine in 2015. And it calls out a couple of different environmental factors, so multi-level environmental factors. So kind of the big picture things like culture and economics. So this might be, we might be able to change those, but they can be a little bit more difficult to change in the short term. But maybe what we can address are things like the community environment and the family environment. And our best opportunity to do so is in the first 1,000 days, where there's the greatest opportunity for plasticity and reversibility. And that begins at the point of conception until about the baby's second birthday. And digging a little bit more into those community environments in association with obesity. The data I'm showing here is from one of the studies that we did a couple of years ago at Geisinger, and we looked at our EHR electronic health record data over a 20-year period to look and see what are the associations between community environments and BMI. And we identified 163,000 kids who had multiple BMI measures so we could evaluate trends. And then we identified where they lived, and there were about 1,300 communities that they lived. And then we tried to characterize those communities by the level of community socioeconomic deprivation. And that was a composite measure of the factors that are noted on the slide. And what we found is that by age 3, the children who were living in the communities with the highest level of socioeconomic deprivation, which is the top line, those children by age 3 started to an upward climb in BMI. And it was a little bit later for the children who lived in the communities with low levels of socioeconomic deprivation, or the more affluent communities. And then over time, they both followed a similar graph, but to a greater degree. And there was a widening disparity between the children who lived in the communities with low socioeconomic deprivation, or communities with high levels of deprivation compared to those with low levels of deprivation. And I bring this up because community socioeconomic deprivation is partly the consequence of policies that control zoning, economic development, housing, taxation, and transportation. And these policies, while not directly related to health, do lead to structural conditions that regulate risk and facilitate healthy energy balance behaviors. And these are subject to change. One of the other environments that is subject to change is the family environment. And there's a preponderance of evidence about positive parenting, and specifically responsive feeding. And responsive feeding means the prompt, contingent, and appropriate response to the cues that the child exhibits, maybe related to hunger and satiety, as illustrated on the slide. And we know that by paying attention to those things and being responsive, that is associated with better children's eating behaviors from infancy through adolescence, as well as weight status. In fact, the evidence is now so strong that guidance on responsive feeding is included in the 2020 to 2025 dietary guidelines for Americans. So at Geisinger, we have been focusing on really understanding what we can do to prevent childhood obesity, because we serve a rural population and there are disparities between urban and rural populations, particularly related to obesity. So we have brought to life this model proposed by Dr. Dietz and others at the National Academies in 2017, this idea of clinical and community integration. And so specifically, we work in those communities in the Geisinger region that have high levels of socioeconomic deprivation. And we engage the parents and the caregivers in assessing their parenting and feeding practices to help them identify their knowledge gaps and needs. And then we share that information with their child's pediatrician, who provides tailored, family-centered preventive counseling. And with the patient's consent, we also share that with the social or community organizations that they are also receiving care from. And for example, that would include WIC for a younger population. And we've demonstrated through a randomized control trial that is a beneficial way to bring this model to life and to prevent childhood obesity. And we have another study we just finished at the bottom of the screen that we'll be publishing on over the next year or so. So turning from prevention to treatment of obesity in childhood, there's really not much to say, other than in 2023, we had our first ever clinical practice guidelines from the American Academy of Pediatrics. This is an exciting and important first step. However, healthcare systems are really trying to build the capacity to be able to respond and implement these guidelines. And while we at Geisinger have had an evidence-based program as recommended by the guidelines since 2007, there hasn't been much interest in in participation in referrals to the program. So in 2023, we did see an increase in referrals. And in fact, 530 children were referred to the program. But I want to give you an idea of the scale, but there were 100,000 children that we cared for that were eligible for referral. So we still have quite a lot of work to do with treatment. And then I mentioned earlier that we were seeing significant increases nationally in among girls ages 16 to 19 years of age in class 1 and class 2 obesity. And that's a concern because obesity is definitely related to the unfortunate position that the United States finds itself in spending more on healthcare dollars during pregnancy, but having the highest maternal morbidity or mortality rate. So that's indicated by the red line on the graph. And you can see some of the other higher income countries, how we compare to them, and that we're going up, so not even trying to get closer to where they are. And then this graph also illustrates some of the disparities we see within the United States. So I mentioned again, those girls having more increases in class 1 and class 2 obesity as they enter their childbearing years. And that's a concern because persons who start their pregnancy with class 1 or class 2 obesity have more obesity related complications and hospital admissions, and the hospital costs during the pregnancy are 5 times higher. So with that, I'm going to end the life course and turn the podium over to Dr. Pal Wiley, who will talk about cardiometabolic conditions and obesity during adulthood.
Thank you so much, and I'm pleased to be here this morning. So I'll be focusing on really the complexity of obesity and how it relates to cardiometabolic disease. I'm trained as a cardiologist, so that's the lens that I look at the issue of obesity and how it connects to the cardiovascular health of the patients I care for. So we know, as mentioned a bit previously, that the trends in the prevalence, the rates of obesity in the United States have been increasing over the past several decades. Data from the Centers for Disease Control using National Health and Nutrition Examination Survey data shows prior to COVID that we had significant increases across all racial and ethnic groups, particularly for women, in rates of obesity. And when we think of severe obesity as well, we see increasing rates. And this is those who have a body mass index at or above 40 in the US population. So for us caring for patients with cardiovascular disease, we're also seeing the impact of the increasing rates of obesity in the US on cardiovascular mortality, where we know since 2011, we've had a deceleration in cardiovascular mortality. But we also know that obesity affects the rates of other chronic diseases in the US, and that relates to also seeing a deceleration in cancer mortality reductions as well since 2011. And again, this shows how the epidemic is contributing to not just cardiometabolic health, but cancer, cancer mortality, and other chronic diseases. So in the cardiovascular space, we've worked with the American Heart Association to really define how the disease of obesity contributes to cardiometabolic as well as kidney health. And this diagram really shows the stages of cardiovascular kidney metabolic syndrome, which is a continuum of risk related to excess adiposity, but really dysfunctional adiposity that promotes chronic inflammation, endothelial dysfunction, insulin resistance, which promotes the development of diabetes, and subsequently can contribute to cardiovascular risk and cardiovascular disease, but also the development of kidney disease and heart failure. And so we need to do a better job at thinking about how we care for patients in a multidisciplinary way and think about all of these diseases is interconnected, but again, related to excess adiposity. And for women, given high rates of obesity, particularly among racial and ethnic minoritized populations in the United States, this contributes to disproportionate rates of cardiovascular disease. And cardiovascular disease is a #1 killer of women in the US. And so what we're learning and what we've known for many years is that obesity as a disease is related to issues and functions within the brain and how that relates to food intake, as well as the set points related to body fat. So one of my mentors who really talked about what obesity is as a disease really highlighted that obesity is not about body size. It is not about how you look. It is about how the body relates to body fat and the functions related to dietary, to food intake, and to hunger related to the brain's control of food intake. And so we know within the hypothalamus, within the brain, that controls appetite and food intake. And so those controls actually contribute to how the body tries to get to a certain set point related to body fat. And so it's not about willpower in terms of trying to reduce food intake and promote weight loss. It is really thinking about how do we address what's happening in the brain, and when we think about treatments for obesity. And then, as I said, the body works to get to a certain set point in terms of fat mass. And so when that set point is affected by decreasing food intake in the setting of obesity, that can lead to hunger and appetite changes that in many ways relate to, again, trying to get back to a set point in terms of fat mass. And that contributes to the difficulty with weight loss in the setting of obesity. And so the drugs that we now have, the GLP-1 receptor agonists, really work in these networks within the brain to affect appetite and lead to reductions in weight. And so the GLP-1 receptor agonists, these glucagon-like peptide 1 receptor agonists, these new medications like Ozempic or semaglutide and tirzepatide that are available for the treatment of obesity, are promising treatments, again, because of the effects that they have in the brain and how they work in appetite suppression. But they also work by other biologic effects on other parts of the body. And that's in many ways their impact and their promise for the treatment of cardiometabolic disease. They have, these drugs are known to have impacts on endothelial function. They're known to have impact on insulin resistance, as well as chronic inflammation. And so these are many of the pathways that relate to why we're seeing benefit in patients with obesity, but also with cardiovascular disease. There have been several trials over decades to look at the cardiovascular risk reduction for drugs like semaglutide and tirzepatide, these GLP-1 receptor agonists. And they've been used for many decades for the treatment of diabetes, as well as the treatment of obesity in the setting of diabetes. Most recently, we have data from the SELECT trial, which was published last year in the New England Journal of Medicine, which showed for patients with overweight or obesity with a body mass index at 25 or above, but with known cardiovascular disease, that there was a 20% reduction in cardiovascular events in those individuals and those patients with the treatment of semaglutide as compared to placebo. And that, again, these were patients with obesity or overweight but also with cardiovascular disease, but notably with no diabetes. And so this was one of the first trials to really show that these types of medications could have benefits for patients with cardiovascular disease and with obesity, and really has been a game changer in thinking about how do we treat patients with cardiometabolic disease. And so we now are looking forward to results from future trials that are looking at how these types of medications can have benefit for patients with not only cardiovascular disease, but kidney disease, more specific cardiovascular diseases like heart failure, atrial fibrillation, as well as other heart rhythm disorders. And so for those of us in the cardiovascular space, these, as I said, have been game changers, but it also highlights how do we think about treatment of patients who may not have access to these types of medications, and how do we make sure that patients really have access to the continuum of treatments from not just pharmacotherapy, but also lifestyle interventions, as well as bariatric surgery. And so again, for those, because we know that obesity disproportionately affects populations who are under-resourced in the United States, and particularly in racial ethnic minority populations, we need to think about and focus on health equity and accessibility in obesity treatment, and think about how that relates to what we do in the scientific community. And so we worked on a scientific statement that highlighted the social determinants of health that relate to obesity and cardiovascular disease, including the psychosocial, environmental, and socioeconomic factors that relate to the development of obesity that can be incorporated into interventions, and really thinking about how do we develop more multi-level interventions, many of which would benefit from community engagement and working with communities most impacted by obesity to develop and design interventions and implement interventions with the buy-in from the patient being cared for. We do have data from public health interventions that community engagement can influence the adverse effects of obesity, but also can reduce the prevalence of obesity in communities. But we also have data to show that targeting social determinants as well can improve cardiometabolic health. For instance, the Moving to Opportunity study showed how housing vouchers could and allowing individuals to move to areas of with higher socioeconomic level or lower levels of socioeconomic deprivation can reduce rates of obesity, particularly for women, and also reduce rates of diabetes. We have data to suggest that changes to the built environment or the physical environment in which individuals live can reduce rates of obesity. And that's specifically related to increasing public transportation resources in communities. There's emerging data to suggest that interventions targeting food as medicine, or specifically providing produce prescriptions, can serve as a treatment opportunity for patients with obesity. And again, engaging communities, working directly with community members through advisory boards, through patient-centered approaches and community-centered approaches, can serve as treatment opportunities as well. As I said, we know that targeting the social determinants can reduce rates of obesity, but we also need to understand more about how these social determinants really affect the biological pathways that connect risk of obesity to the development of cardiovascular disease. There are specific pathways that by which social determinants of health, adverse social conditions, can influence biology by promoting chronic stress, which leads to release of stress hormones that influence adipose tissue and promotes inflammation within adipose tissue. There's release of specific markers from this adipose tissue that promotes cardiometabolic risk, including inflammatory markers like TNF alpha and interferon gamma and other pro-inflammatory markers. But we also know that adipose tissue in and of itself actually can release these pro-inflammatory markers that promote insulin resistance and that can lead to cardiometabolic diseases. And again, start that continuum of cardiovascular kidney metabolic syndrome. And so where we need to think in terms of science is, in many ways, how do we target some of these biological pathways? How can some of these new medications like the GLP-1 receptor agonists work in these pathways? How do some of these medications or how do some of these social determinants actually limit the effects of these medications because of the adverse biological effects of adverse social conditions? So to conclude, as I said, we're moving towards a more patient-centered model for thinking about the treatment of cardiovascular kidney metabolic health. And many of these, the tools that we have already for the treatment of obesity also need to they need to be accessed for patients across the treatment continuum. There needs to be a approach that really centers the patient and creates an opportunity for multidisciplinary treatment for patients with obesity. And so but to do this, we also need to think about how are we training the next generations of clinicians who are caring for patients with obesity. How do we address weight stigma and bias in the healthcare setting? And again, how do we provide opportunities to build these interdisciplinary teams that can coordinate care and address not just the treatments for obesity, but also the social determinants that limit the access to care as well as quality outcomes for all patients. So thank you so much, and I'm happy to turn it over to my colleague.
Good morning, everyone. It's a pleasure to be here with you. I think we all know, all the women in this room and frankly, and online and the men, know that women have some barriers to overcome just generally in society. You know, we think about employment and women, our pay is not equal to men, generally speaking. We think about the appearance demands put on women. And, you know, every magazine you look at, glamorous and trying to meet those societal expectations. And I would be willing to bet that most women listening to me right now would say they've been disregarded by a medical provider at some point in their lifetime. So that's one area of bias, right? Now start thinking about that coupled with also having obesity. In employment, women with obesity in employment earn less than women generally, fewer promotions, harder being hired, more trouble getting jobs to begin with. Those are all problems. And when you add yet another bias, say a racial bias, Black women have a harder time, even than someone like me in the employment arena. And you look at that in appearance demands, add obesity to being a woman. Do you know how many times I've been ridiculed because of my size? By people that don't even know me. Walking down the sidewalk trying to get some exercise and people calling out of a car, you big fat pig or shamu. They're always large mammals, I'm just saying. You know, trying to live up to society's expectations, which Granted, in a perfect world, we wouldn't care, but it's hard to avoid that. And it's harder when you have obesity. And then when you hit the medical community and you are a woman plus having obesity, that's really hard. You see physicians and other medical providers who attribute everything to your weight. Anything could possibly be wrong with you. It's about your weight. You need to lose weight without any offers of helping you, of course, with that daunting proposition. And as if you hadn't thought about that before and tried everything you could do to lose weight. I once had an orthopedist diagnose me with obesity pain, when in reality, what he missed was a 60-degree curve in my spine because I have degenerative scoliosis that's very severe. You run into problems like that more often than I care to even think about. There are also disparities in some areas, like, and just here are just a couple examples. For instance, people with obesity, especially women, often put off preventative screenings. I put off having a second mammogram for 15 years because the experience I had on my first one was humiliating. Inadequately sized gowns, the machines don't fit particularly well when you have obesity. The lead apron that they wanted you to wear to protect other parts of your body didn't fit. So I didn't go back for 15 years, and I only went back then when one of my closest friends was diagnosed with breast cancer, and she made me promise to go. Mammograms are also not always sufficient for people with obesity, for women with obesity. They underdiagnose, and because of women who don't get treated as soon for preventative screenings, usually people with obesity present with a later stage of breast cancer, which is harder to treat, of course. It's just one example. Another example is in drug trials. In a lot of drug trials, women are underrepresented and people with obesity are underrepresented. I take a blood thinner because I have a genetic clotting disorder, blood clotting disorder, and I wanted to try one of the new drugs that were easier to take, didn't require monthly blood work. And my hematologist said no, because those drugs were not tested on people with obesity. We don't know how they're going to react. So I couldn't take advantage of that treatment. And now that we have new treatments emerging daily in the obesity space, people have difficulty accessing those too. You know, most people don't have access to those drugs. My experience is that one of the newer drugs is helping me manage my weight and my chronic disease of obesity. I'm lucky because I'm a retired federal government attorney and I took my healthcare into retirement. And OPM made the wise decision of requiring federal insurers to cover obesity medications. So mine is covered. But you know what? Healthcare shouldn't come down to luck. It just shouldn't. And we look at the cost of some of the obesity medications. Some aren't that expensive, frankly. Others are. And we think, well, they're going to cost too much. Well, where do we talk about that in healthcare? What do we get out of healthcare? Healthcare costs money. And we hope to have a longer life, a better quality of life. We're not looking for cost savings. But in the obesity space, everybody's asking about, well, where are the cost savings? We just want parity with other diseases. I want to be able to treat my obesity, just like cardiovascular disease and other diseases that we've talked about today. So thank you very much for listening. And I'd like my friend and colleague, Tracy Zavenich, will close us out.
Thanks, Patty. And thank you to the Society for Women's Health Research for the opportunity to join you today to talk about this very important and timely topic of women and obesity policy. I think Patty did an excellent job of bringing all of this important science that was shared with you to life, right? Her story is incredibly powerful. Her personal experience matters. So from a policy, so I'll tell you a little bit about OAC. So the Obesity Action Coalition is the leading national nonprofit dedicated to serving people living with the disease of obesity. We have over 80,000 members, and our mission is really to elevate and empower those affected by obesity through education, advocacy, and support. From a policy perspective, here I'm sharing a little bit of data on the types of health insurance coverage that women hold. So for women ages 19 to 64, the majority have health insurance coming from their employer. No surprise there. Followed then by Medicaid at 19% and direct purchase insurance, which includes the Affordable Care Act exchange marketplace plans at 9%, and 3% of women having military or VA coverage, also including non-elderly women with disabilities that qualify for Medicare. Then on the right-hand side, you see the representation of women in Medicare. So you can see that 32.4 million women are Medicare beneficiaries. That represents 55% of the Medicare population. So most beneficiaries in Medicare are women. Then when we look at obesity rates among women compared to men, on the right-hand side, you'll see that women have a higher rate of obesity compared to men. And then when we look at obesity rates in women across the states, you can see that the states of Tennessee, Louisiana, and Mississippi have the highest prevalence rates of obesity among women. I also did want to call out, I forgot to mention, the uninsured population at 10% for women is also a startling and concerning statistic. Didn't want to miss that one. Here in this slide, this shares some data from the National Health Statistics Report looking at the prevalence of adults aged 20 and over with obesity by different demographic characteristics. And the characteristics include age, race, family, income, and education. And as you can see, I've highlighted the far right column, which represents women across these different characteristics. And you can see that the percentage of prevalence in many of these areas is higher in women compared to men. So for example, in particular, women age 60 and over, non-Hispanic Black women followed closely by Hispanic women, lower income women, women with lower levels of education and lower levels of income represent populations with higher obesity prevalence. So in general, women are living with this serious chronic disease more so than men. From a policy perspective, I'm going to share with you a few of the policy gaps that we see for women and obesity coverage. At OAC, we advocate for the full spectrum of evidence-based obesity care interventions. So that's everything from what you've heard from this morning from my esteemed colleagues from nutrition counseling and intensive behavioral therapy, to FDA-approved medications, to metabolic and bariatric surgery, and there are some newer FDA-approved endoscopic therapies as well. We advocate for the full spectrum of care there. And then when you look at policy and coverage, there are gaps across these payer types. And at OAC, we advocate for improved access to care across these payer types. What we find when we look at coverage data is that there is limited and variable coverage for obesity care across these payer types. I'm going to highlight Medicare policy as an example for today. In Medicare, we see opportunities to improve coverage in Part B and Part D. In Medicare Part D, there is limited access to the types of qualified and trained providers that can administer intensive behavioral therapy. Also in Part B, we see limited access to the settings of care where a beneficiary can receive intensive behavioral therapy. So as it stands today, you can receive intensive behavioral therapy if you go to your primary care provider in a primary care setting. but we know that there are other very qualified and trained healthcare professionals outside of a primary care setting who are not primary care providers that can deliver high quality intensive behavioral therapy services. For example, other specialty physicians, registered dietitians, clinical psychologists, just as a few examples. Then in Medicare Part D, the current statute actually prohibits coverage for drugs used for weight loss. And this comes from the Medicare Modernization Act passed in 2003, where that language is interpreted more broadly today for not being able to cover the newer generation of obesity treatments. So this statute needs to be updated to catch up with the advances and innovations in science and really improve access to these life-changing and life-saving treatments. And we all know that the policy implications of updating a Medicare policy, for example, go much broader. There's a ripple effect. When Medicare changes a policy, we oftentimes then see private insurance companies update policies as well as public programs as well. So that is the Medicare policy is a really great opportunity to improve coverage, yes, for the Medicare beneficiaries, for women in Medicare, but then for the broader population as well. And there is one policy solution that is has been proposed and is under discussion right now. It's called the Treat and Reduce Obesity Act. And this legislation has been around since 2012. The Obesity Action Coalition was in those initial discussions and has been advocating for it ever since. So over a decade now. This congressional session has been very positive. This legislation currently has strong bipartisan co-sponsorship in both the House and the Senate. The committees that are looking at this bill are House Ways and Means and Energy and Commerce, as well as Senate Finance. And the Congressional Budget Office is actively reviewing and working toward determining a score today. So there are some key next steps that we really want to encourage and try to advance for this particular policy solution to improve access to care in Medicare. In particular, we're working closely with the Ways and Means Committee to ask them to have it included in the next committee markup. And as well, working with the Senate Finance Committee to potentially have it included in the Chronic Care 2.0 package. So the overarching goal here is to advocate and advance this legislation in 2024, have it hopefully included in an end of year package. So we welcome other organizations, we welcome other voices to join us and advocate in support of the Treat and Reduce Obesity Act to move it along the steps of the legislative process that it needs to take to be successful in passing this year. You've heard from Patty, her powerful story. Updating this particular policy means so much to women. It means so much to Medicare beneficiaries, and it means so much really for all Americans. So thank you so much. And I'll turn it back over to Katie.
Right. Well, thank you all. And I think there's a few key takeaways here. We have just a few minutes, time for a couple of questions. And I'm realizing now I walked away from my questions, and that's okay. Folks online, feel free if you have a question, pop it in the chat and I'll pop over there. But a couple of things. I think on the policy side, what Tracy was just talking about is really critical. So over 10 years now, right? And we know that legislative change and policy change takes time. Obviously, the way we approach particular complex policy issues takes a lot of time. But we do think that this is really important. It's far past time to make these changes. Okay, this is, I would say, an easy change, although nothing today is easy. But with such strong bipartisan support and hearing as well the challenges related to women in particular, I think this could truly make a difference, right? This is actually about health and well-being and optimizing health and well-being It's not about particular language, right, or category that we're sort of putting people into. So I would say that. And maybe we'll start with anyone who wants to jump in, and I would remind people, please use the mics that are there. But when we think about women in particular, we've heard a lot about sex differences. We've heard about also the societal issues that women face, just in terms of their health and their appearance and gender roles, et cetera. What do we think is the greatest challenge that women living with obesity are facing today? And maybe, Patty, I'm going to start with you because I think you did a really good job of framing this earlier.
That's what I get for doing a good job. Wait, it's so hard to narrow it down to one thing. I think one of the biggest challenges women with obesity face is getting past their own weight bias and treating themselves badly because they haven't on their own been able to control them, to manage their weight. I think that's a big challenge because a lot of those women don't even want to seek treatment, even when it's available, because they're just, it's hard because I was told my entire life, I've had obesity since childhood, that it was all my fault and all my responsibility, and that I could do this on my own. And it's only, honestly, in my 50s, I started working with an obesity medicine provider who knew more about the science. And the science you talked about, it just, once you learn more about that, you realize this isn't all on my shoulders and I'm not always in control. My body is saying things on its own that I can't control. And I think that's one of the challenges that women with obesity face.
I would also highlight just the role of the environment that women face, that in terms of the limited access to resources around physical activity, around healthy foods, but also the stressors that contribute to not just what women do in terms of health behaviors, but just the actual biological effects of chronic stress. And so when women are disproportionately affected by caregiver stress, by as you mentioned, limited differential pay, differential socioeconomic resources, all of that stress has biological effects, and that contributes directly to how your adipose tissue works. And like I said, those have downstream effects on your cardiometabolic risk.
I'm so glad you brought that up because I think it lends itself to the broader conversation of this intersectionality when we think through health equity, right? So, and you did a great job of talking about this, but just to reiterate, right? Like you are already at a disadvantage if you are a woman, and then you add on the intersectionality of that, whether that's you're a woman of color, you are a woman who lives in a rural area, age, right, can be a big factor as well. And so if you think about all of these things on top of each other, it sort of further magnifies a lot of these issues. So, and we see that across the board in all of the areas that we look at. So, okay, I can see we're at 11 o'clock. I'm going to ask my last rapid fire question. And I'm sorry if folks have questions, please pop them in the chat or just come up to us following. But obviously we are here up on Capitol Hill. And I think Tracy, you did a great job of talking about like, what are the real tangible solutions that we can use to address these issues? Just in your sort of thinking, and maybe we'll start from this end and we'll work our way down. So Patty, you get to go last. What is the one thing you want people to take away from this conversation today?
I would just say that there's no one solution to fixing obesity. I think we're going to have to work together. We're going to have to work at individual, community, systems, policy levels to make meaningful change for people living with obesity.
I just would reiterate that girls are becoming heavier and establishing obesity at 2 to 4, 5 years of age. It's persistent, it's progressive. And we haven't done much in terms of prevention, large scale to help them, but we're making some, important gains. So it's going to continue. It's important to pass this legislation now to help the women in adulthood and all persons with obesity receive care and treatment.
I would add quickly, we still have a lot of research questions to answer. As I mentioned, how some of these medications are affected by social determinants. We need to better think about how do we better engage diverse populations in clinical trials related to obesity, diverse women, and make sure that we're looking at those who are, again, disproportionately affected by rates of obesity.
We're at a time period in obesity medicine where they're actually bringing hope. There's actually hope for people with obesity now, hope for treatments. So pass the Treat and Reduce Obesity Act. Find the money to do it.
I could not have said that better myself. So thank you all. Please join me in thanking our amazing panelists today. We so appreciate you taking the time to be here. Thanks to the folks who joined us online. Stay connected with us. It's here on the slide.